Good morning. Welcome to Medical Grand Rounds. It's certainly my distinct honor to introduce this morning's Grand Round speaker. Dr. Ruth O'Regan is a new addition to the leadership team at the University of Wisconsin Department of Medicine as the new division director for Hematology and Oncology. She received her medical school education at University College in Dublin, Ireland. After some additional training in Ireland, she came to the United States and did 2 years of training at the Medical College of Wisconsin, followed by some training at Northwestern, including her Hematology Oncology Fellowship. After spending a short time there on faculty, she went to Emory University, where her career really blossomed and her leadership potential became evident to everyone. She has held titles as director of the fellowship program of hematology oncology at Emory, vice chair for educational affairs, associate professor. She has had received numerous honors and awards, including the Compassionate Care Award, a top doctor designation, excellence in teaching, and most recently the Physician of the Year Award for the Department of Hematology and Oncology at Emory. She's on numerous editorial boards and is the section editor for breast cancer for the journal Cancer. She's had numerous grants, and we are very, very pleased to have her present Grand Rounds this morning on the evolution of targeted therapies in breast cancer, new opportunities for cure. Please give Ruth a Wisconsin welcome.
Well, thank you, Alan, for that very kind introduction. Good morning, everyone. So what I'm going to try and do today is kind of take you through a tour of kind of where we are in treating breast cancer. Given this is a Department of Medicine audience, I try to focus a little bit on drugs that you might have patients in your clinic that we're taking as well. So just as far as breast cancer, in fact, as you all know, breast cancer is very common. The estimate right now is that between 1 in 7 and 1 in 8 women up to age 90 will be diagnosed with breast cancer. As you get older, you're more likely to get breast cancer as well. The numbers right now are there's probably about 220,000 cases diagnosed annually in the US. We still lose 40,000 women a year to breast cancer, so there's a lot of work still to be done, despite what I'm going to show you today. And overall, the outcomes have improved somewhat for 3 main reasons. The first reason is greater awareness. As you probably know, breast cancer advocacy has a huge effort in basically making women aware of their breasts and telling them to go and get their breast checks and their mammograms. I think if we watch the NFL, the whole month of October is focused on breast cancer. Secondly, early detection. We're not going to talk about screening today because it's somewhat controversial, as you know, but overall it has made some inroads in helping diagnose breast cancers at earlier stages. And then what we're going to focus on today is the more effective therapies that we have. So what do we mean by targeted therapy? What does that really mean? This is really a goal for not just breast cancer, but really all of oncology. And the way I kind of think about it is that what you want is the cancer cell to have a protein or a gene target that is either only present on the cancer cell, which is very uncommon, or is expressed or is present at a higher level in the cancer cell compared to the normal tissues. Because really what we're trying to do here is rather than using a one-size-fits-all approach, which we've done for years, where we treat everybody the same, we really want to have agents that basically will target just the cancer cells, but will lessen the off-target effects and therefore decrease the toxicity from these drugs. So we want very effective drugs with very little toxicity. And we've made some headroad into this, but we still, I think, have a long way to go. So what I'm going to talk about first is just kind of a history and kind of where we've been as far as targeted therapy in breast cancer. And this has been around for a long time, as you will see. So some of what I'm going to show you is actually from The Emperor of All Maladies, which I would encourage you to read if you have not read it yet. It's a very interesting book about the whole evolution of cancer and cancer therapy globally. So basically, the whole kind of link between targeted, if you like, targets in breast cancer dates back to the end of the 19th century. So Mr. George Beatson was a surgeon in Scotland. They always call him Mr. in the UK rather than Doctor. And he'd been kind of hanging out with the farmers up in the Scottish Highlands. And the farmers had told him that when they removed the ovaries of the cows, something happened to the cows' udders in that they were unable to lactate anymore, and the quality of the udders were essentially changed. So Mr. Beatson was kind of interested with this because he was kind of saying, well, there appears to be a link between the ovaries and the breast. Nobody knew what it was because we didn't have estrogen at the time, we didn't have the estrogen receptor, we didn't know what was going on at all. So he went ahead and he had 3 patients who were premenopausal with breast cancer, and he removed their ovaries. And what he found was that their breast cancers all shrank dramatically. So it kind of proved the same thing that was happening in the cows, that there was a link between the ovaries and the breasts. He then went down to London and kind of presented his data, and some of the surgeons in London tried to repeat what he had found. And what they found is that it did work, but it only worked in 2/3 of women. So 1/3 didn't respond at all to having their ovaries taken out, but 2/3 of them did. And this became a big mystery because nobody could really understand why taking your ovaries out would help some breast cancers, but not other breast cancers. Of course, everybody's looking at me now going like, well, of course we know why that is now, but at the time we didn't know it. So the next critical thing that happened was the discovery of the estrogen receptor. And the estrogen receptor was discovered by Elwood Jensen at University of Chicago. Just to show you how long this essentially took, he first discovered that when you give estrogen to mice, it localizes in the female reproductive tract, and he discovered that in 1958. 10 years later, he finally discovered the estrogen receptor, which is shown up here. This is estrogen receptor alpha. And then it took him another nearly 20 years to actually clone the receptor. So it was a whole career of work to basically discover this estrogen receptor and essentially why estrogen, or how estrogen essentially worked and bound to target tissues. Now, around the same time in the United Kingdom, ICI Pharmaceuticals had come up with a drug called 46474, which we now know as Tamoxifen, which everybody has heard of. Tamoxifen was initially developed as a contraceptive. However, when they gave it to rats, it actually induced fertility. And as you know, we do use these agents now for fertility purposes. So what they did was, again, just based on some of the information that was out there, they said, well, let's see what would happen if we treat women with breast cancer with Tamoxifen. So Mary Cole, who was a physician in the UK at the time, did a small clinical trial where she treated 46 patients with this drug, ICI 46474, and she noted that 10 of them had a good response. Now, previous to that, people have been using estrogen, would you believe, to treat breast cancer, and we still do that, actually, and also androgens. But the advantage that Tamoxifen had over these other drugs was the fact that it had much fewer side effects. But still, there was this kind of conundrum about, well, why do only 10 of these women respond? Why didn't all the women with the breast cancer respond to this drug? Well, the mystery was finally solved in 1973 by Craig Jordan, who actually spent most of a lot of his initial time here at University of Wisconsin, and I actually worked in his lab for 7 years. So what he found just prior to him coming to University of Wisconsin was that if you look at cancer cells that express the estrogen receptor, they're the ones that are responsive to tamoxifen, while cells that lack the receptor do not respond. So what he basically found with it is that if a cancer cell has the estrogen receptor, it binds tamoxifen, and the drug then shuts off estrogen responsiveness. So basically, it doesn't allow estrogen to get to the cancer cells, and they essentially die. Now, this may seem very kind of obvious, and it certainly in this era it certainly is, but it was a very important finding because it was the first time in the history of cancer that you had a drug, a target, and a cancer cell that kind of were all linked together, and you kind of worked out essentially why this drug worked. Now, tamoxifen has gone on to be like a huge success story in treating breast cancer. This is looking at its use in early-stage breast cancer. This is a meta-analysis comparing tamoxifen for 5 years with placebo for 5 years. And what you can find here is that if you look at recurrence and survival, There's a highly significant benefit or decrease in recurrence, whether the cancers are node negative or lower risk or node positive or higher risk. And you can see the numbers here, about a 15% risk reduction. When you look at survival over here, again, you see a significant benefit. It is greater in the patients with higher risk disease, but you can see a highly significant benefit for using tamoxifen regardless of nodal status on survival. So even though we have some newer drugs, many of us still use tamoxifen a lot. And just to remind you, it's the only drug you can use in premenopausal patients, which we'll talk about in a second. So this little cartoon kind of describes how tamoxifen works. So basically, what happens when you have estrogen, here's the estrogen receptor in here. When the estrogen receptor binds, when estrogen binds to the estrogen receptor, what happens is two receptors dimerize together. They recruit all these co-activators and then result in gene activation and estrogen-stimulated gene activation. If you have tamoxifen, it also binds to the estrogen receptor. But the estrogen receptors now only partially dimerize. They're not able to bind these co-activators anymore. And what happens is you basically turn off gene activation, at least in some tissues, so I'm going to show you not in all tissues. But this is essentially how it works in the breast. Now, going back to Dr. Jordan, who was here, and while he was here, he found something extremely interesting and unexpected about tamoxifen. And that was that, although it had anti-estrogenic effects on the breast, it had estrogenic effects on other parts of the body. And the way he discovered this was a pretty simple experiment, where what he did was he took a mouse, put an ER-positive breast cancer on one side of the mouse, and an ER-positive uterine cancer on the other side of the mouse. He then treated the mouse with tamoxifen, and he found that tamoxifen completely controlled the growth of breast cancers, as you can see shown here. But lo and behold, the uterine cancer started growing. So this was really the first sign that tamoxifen didn't work the same on every target tissue, and it really was a very important finding. Subsequently, of course, we now know that tamoxifen is associated with uterine cancer in postmenopausal women. This is from the prevention trial, which Howard Bailey may have showed you a few weeks ago, showing that you get about a 3- to 4-fold increased risk of uterine cancer in patients taking tamoxifen compared to placebo, as you can see shown there. So this just kind of summarizes the good, the bad, and the ugly about tamoxifen. And we pretty know everything about this drug at this time because we've used it for so long. So I divide into its estrogenic effects and anti-estrogenic effects, and its beneficial and less beneficial effects. On the positive side, its anti-estrogenic effects, of course, this is why we give it, treat and prevent breast cancer. So we know that. We know it's an anti-estrogen on the breast. However, on the positive side, looking at the estrogenic-like activity, it does maintain bone density in postmenopausal women. So you know the drug raloxifene, this is just a shorter acting form of tamoxifen. And actually in a prevention study that compared raloxifene to tamoxifen, the two drugs were equally effective in maintaining bone density in postmenopausal women. It also lowers LDL cholesterol, so it lowers total cholesterol. And there's always been a thought that it potentially does decrease the risk of coronary artery disease, but it's never really been definitively shown that it does. But if you look at the studies where tamoxifen was compared with aromatase inhibitors, there did appear to be a protective effect on the heart. On the negative side, however, the estrogenic effects are responsible for the increased risk of uterine cancer in postmenopausal women, probably responsible for the thromboembolic events that we see with this drug, and certainly play a role in the increased risk of stroke that's seen in postmenopausal women. The anti-estrogenic effects are mainly kind of menopausal symptoms like hot flashes and vaginal dryness. And these are actually the symptoms that most patients complain about more than anything else with this drug. So overall, it is a very safe drug. And just with regard to the uterine cancer, probably about 30 years ago or so, the World Health Organization looked at tamoxifen and looked at the risk-benefit of this drug and basically said that the benefit in terms of the treatment for breast cancer outweighed significantly the risk of uterine cancer. So it is a problem, but it's one that I think that it's relatively easy to deal with. So I just want to you hear a lot of things about tamoxifen and uterine cancer and its effects on the uterus. So I just wanted to just clear up a few myths that I always hear in my clinic about this. The first one is that there's only an increased risk of uterine cancer in postmenopausal women. This was shown very conclusively in the prevention study. So if you have a premenopausal patient, which are the patients that we generally tend to treat with tamoxifen, there isn't an increased risk of uterine cancer. The second thing is that in the prevention study and the other studies that have been done, almost every uterine cancer that's been associated with tamoxifen has been stage 1 and grade 1, so these patients are all cured with hysterectomies. it's not associated with an aggressive form of uterine cancer. The third, I think most important thing is there is no screening recommended to screen for uterine cancer in patients on tamoxifen. What's recommended is an annual pelvic examination and a rapid workup of uterine bleeding if that occurs. That's what's recommended. Historically, people have looked at screening with ultrasounds and random biopsies, but they're not recommended. So if you look here at uterine ultrasound shown here, here's a normal uterus, and here's a uterus that's hyperplastic due to tamoxifen. Tamoxifen almost always causes hyperplasia of the uterine lining. So how could you tell if there's a cancer in there? Well, you basically couldn't, and that's essentially why it's not a useful tool. And then doing a D&C with random biopsies, of course, really makes no sense because there could be a cancer in there that you're going to miss. So this is a continual thing that we have discussions with the gynecologists, but patients get very worried about it, but these are actually the facts, essentially. The other thing I always hear is, tamoxifen is going to put me into menopause. Well, it doesn't actually do that, but it can cause amenorrhea and it can cause menstrual irregularities. So it's very important when somebody's on tamoxifen that you check their menopausal status by measuring pituitary hormones and estradiol. And the last one, which is also important, is if you give tamoxifen to a premenopausal patient, she's probably going to develop ovarian cysts. At least 3/4 of women on premenopausal women on tamoxifen do develop these cysts. Again, they get very concerned about it, but it's not associated with ovarian cancer. It's just certainly a benign cyst. So the next drugs that kind of came out were the aromatase inhibitors, which are shown here. Now, aminoglutamide, you've probably heard about, has been around for years. It is an aromatase inhibitor, and it's actually a pretty effective treatment for breast cancer. The problem is that it doesn't selectively target this reaction, which is the one that you want to target. It also targets the aldosterone, cortisol pathways, as well as the androstenedione pathway. So the problem with this drug is it had a lot of off-target toxicity, so that's why essentially it wasn't used. Subsequently, however, these selective aromatase inhibitors were developed, shown here, and they do selectively target this aromatase enzyme here. Now, as you all know, in postmenopausal women, the way you make estrogen is by converting androgens to estrogens. So what these drugs do is they block this enzyme so you get a profound decrease in estrogen levels. Now, you may ask, well, what happens to the androgen levels? Well, they go up slightly, but not to an amount where women actually develop any androgenic side effects from the drugs. So these work very differently from tamoxifen because what they're doing is they're actually reducing estrogen levels, but the effect is the same. You're basically blocking estrogen getting to any cancer cells that are in the body. There are two groups of aromatase inhibitors, non-steroidal and steroidal aromatase inhibitors. These guys here, letrozole and anastrozole, are competitive blockers of the aromatase enzyme. This is exemestane, which is, as you can see, is a steroidal structure. It is a suicide blocker of the enzyme. At least in the early stage setting, there doesn't appear to be any difference between these drugs, and you can actually go from one to another, particularly if patients get side effects. But in the metastatic setting, the two different classes are not cross-resistant. So somebody who got letrozole can go on to get exemestane and vice versa. The thing you cannot do is take a patient who's got letrozole and give them anastrozole. That won't work because they are cross-resistant. So they're pretty useful drugs with regard to that. So when they initially came out, as we always do, we compared them to the standard of care, which was tamoxifen in ER-positive metastatic breast cancer. So these are patients who have not had treatment for metastatic disease before. It's basically comparing each of the aromatase inhibitors with tamoxifen in the first-line setting. And what you find is if you look here, this is usually what we look at as time to progression or disease control. What we found was that the aromatase inhibitors were all better than tamoxifen, ranging from about 3 months up to 5 months in terms of the progression or the control of the disease, you can see shown here. However, there is no survival advantage on these trials. And the reason for that is that patients probably went from an aromatase inhibitor to tamoxifen and vice versa, so that negated the survival advantages that was seen. So basically, you can kind of start with either tamoxifen or these drugs in the metastatic setting. Most times we do start with the aromatase inhibitors, which I should have mentioned on the earlier slide. So one of the things that's important to remember is aromatase inhibitors do not work in premenopausal patients. Because what happens is when you give an aromatase inhibitor to a premenopausal patient, you get a little bit of a drop in estrogen, feeds back to the pituitary starts pumping out hormones. You end up overstimulating the ovaries. So you get a lot of ovarian cysts, but most importantly, you don't reduce estrogen levels. So, and this may sound very straightforward, but the reality is it can be kind of tricky because When we give chemotherapy in the clinic, we often basically put patients into a temporary menopause. And you have to be very careful to make sure that they are postmenopausal, because if you give them an aromatase inhibitor, very often you'll restart their ovaries and they'll start having periods. So it's very important that if somebody's premenopausal before they start chemo, you give them tamoxifen, not an aromatase inhibitor. As far as the aromatase inhibitors in the early stage setting, we do use them very widely, and part of the reason for this, which I'm ashamed to say, is that when these drugs came out, there was a huge amount of marketing done by the different companies trying to point out how much better than tamoxifen they were. But the reality is they're not really that much better. If you look here at this meta-analysis that was published this year, what you find is if you look at risk of recurrence, there's about a 4% benefit for 5 years of an aromatase inhibitor compared to 5 years of tamoxifen, as you can see shown there. And when you start looking at overall survival, this includes death just not from breast cancer, but other causes. You can see, again, it's only about a 3% benefit for the aromatase inhibitors over tamoxifen. So I think it's perfectly reasonable to give these drugs to postmenopausal patients, and I very often do. But if they can't tolerate these drugs, I'm very comfortable putting patients on tamoxifen, because it's much more, this endocrine therapy is so important for patients that it's more important that they're on an endocrine agent, be it tamoxifen, versus nothing at all. And of course, the aromatase inhibitors, you can kind of predict the side effects that they're going to have. They're anti-estrogenic throughout the whole body because of the reduced estrogen levels that they produce. So they decrease breast cancer and also breast cancer risk. They have been used for prevention. They do not increase the risk of uterine cancer, as you would expect, and perhaps decrease it, actually. They do increase cholesterol, so that's something that you have to watch in your patients. I haven't really had to institute a lot of treatment for increased cholesterol on patients taking aromatase inhibitors, but certainly something that you should probably follow. Menopausal symptoms, hot flashes, not as bad as tamoxifen, but you do see those as well. But the most common side effect and the most common reason for patients coming off these drugs is joint pain. We have no idea why these drugs cause joint pain, and I don't think anybody has a good handle on this. But one thing that I've certainly noticed in my clinic is that when we give chemotherapy to patients and put them into menopause, they develop joint pain as well. So it appears to be related to decreased estrogen levels, but honestly we don't know. And if anybody has any ideas why that happens, I'd be very interested to hear them, because it's kind of a mystery, and they can be very problematic. I mean, patients really are very uncomfortable with this. So now moving away from the estrogen receptor onto HER2. So this was the next really huge discovery in breast cancer. So the HER2 is a member of a group of 4 transmembrane receptors that are very important in cancer. In breast cancer, this receptor is overexpressed. Remember I said that we want the target to be overexpressed. The receptor is overexpressed in about 1/3 of breast cancers. So this is what it looks like when you do it. This is you can determine HER2 status either by looking at gene amplification using an in situ hybridization test, or what really is the best way to do it is with immunohistochemistry, where what you find is staining of the HER2 receptor on the membrane of the cell, because that's where it lives. So you can see these are highly HER2 positive. Now, HER2 positive cancers, unfortunately, are very aggressive in their nature. They tend to be grade 3. They have a very high propensity to develop distant metastasis within 2 to 5 years of follow-up. And also, they're associated with the development of brain metastasis. So really, as I'll show you a few slides down, they really had a very, very, very aggressive natural history. However, fortunately, the decade after the HER2 receptor was discovered, this very important drug was developed called trastuzumab. And trastuzumab is basically an antibody that targets the HER2 receptor. It has very high affinity and specificity for the HER2 receptor. It is 95% human, as you can see shown here. What that means is that you're unlikely to get bad reactions to this antibody. I've seen it maybe in one patient. It's very uncommon to have reactions, unlike some of the other monoclonal antibodies that we use in cancer. And the other strange thing about this drug is it doesn't really work very well on its own. You have to give it with chemotherapy. But added to chemotherapy, it's really, as I'm going to show you, has improved outcome for all stages of HER2-positive breast cancer. So here's a kind of a lesson in why directing your treatment towards the appropriate target is so important. So at the time, this was back in the end of the 1990s, at this time when a new drug came out for breast cancer, or indeed any cancer, what we would basically do is just use it in every patient with breast cancer. There was no selection based on what type of breast cancer you had, which, of course, we don't do that as much anymore, but that's the way it was at the time. So Dennis Slayman, who actually discovered HER2 and then went ahead and developed trastuzumab with Genentech, had found in the lab that this didn't do anything if the cancers were HER2 negative. So he went to the FDA and said, we have to look at this drug only in cancers that are HER2 positive, and that was using immunohistochemistry. And eventually he won his case, and they said, okay, you can do the trial just in patients with HER2 positive disease. So this trial basically was patients who had metastatic breast cancer that was HER2 positive with a protein expression on the cell surface. And patients either got chemotherapy alone or chemotherapy plus trastuzumab. And this is the survival data from this. And what they found was that if you added trastuzumab, which I'm going to show you has very little toxicity, to chemotherapy, you prolong survival by 5 months, which may not seem that much, but believe me, in metastatic cancers, that is quite significant, particularly because the patients in the control arm, a lot of them went on to get trastuzumab as part of the compassionate care program they had at the time. So this was a highly positive trial, very exciting. And again, another really, from the time that Dr. Jordan did his animal studies, this was really one of the first trials that had kind of looked at really targeting a cancer, targeting a protein in cancer. So what would have happened if the FDA hadn't listened to him? Well, a few years later, there was a trial done, or a trial published, where they did just that. They basically took patients with HER2 negative breast cancers. What I mean by that is they don't have overexpression of HER2 on the cell surface because, in fact, almost every cell in the body has HER2. So these were cancers that were not HER2 positive. Patients either got chemo alone or chemo plus trastuzumab. And I think you can clearly see here, looking at these curves for recurrence and survival, what you can see here is that they completely overlap and there's no benefit from trastuzumab. So if we had done this trial, we would never have trastuzumab. So that's why it's so important that we're much smarter in terms of how we actually design our trials. So just to show you a couple of other things about how successful this drug has been, I'm going to show you in a few slides what happens with HER2 positive breast cancers when you don't treat them at all. They are very sensitive to chemotherapy, which is certainly a good thing. But this is in the early stage setting. And this is patients with node-positive breast cancer who are randomized to receive chemo or chemo plus trastuzumab. And what you can see here is that there's about a 16% benefit for the addition of this really non-toxic drug to chemotherapy for these patients. But what I'd like to point out here is, look at the recurrence rate for these patients shown here. This is out at about 5 years, 4 or 5 years. 10% of these patients have recurred. That is a very, very small number compared to the way that this cancer would have behaved if you didn't have these drugs. So this was, as you can see here, the p-value is highly, highly statistically significant. So this was a huge victory in terms of treating patients with this aggressive form of breast cancer. There may be patients that don't need trastuzumab, because you can see not all the patients who did not get trastuzumab, not all of them relapsed. But at the moment, because of the fact that it's so non-toxic, we really treat all these patients with HER2-directed therapy. And just to show you how we've taken it a little bit further, this is basically just a trial where we took patients with very low-risk HER2-positive cancers, so they were node-negative small cancers, treated them just with paclitaxel plus trastuzumab for 12 weeks, so a very short duration of chemotherapy, not too much toxicity with it. And this is at about 3 years. And what you can see here is that just over 1% of the patients have relapsed. So almost all these patients are being cured by this drug with some chemotherapy. So really a huge advantage. And one of the things we're trying to do is work out, can we omit chemotherapy in some patients? And we really haven't found a way of doing that yet, but that's certainly something that we're very interested in. As far as toxicity, there's only really one to mention, and that was noted in the initial pivotal metastatic trial I showed you, was that if you give trastuzumab with an anthracycline, there's a risk of cardiotoxicity. So if you look here, this is the metastatic trial I showed you where patients got an anthracycline with trastuzumab. The rate of heart failure was 16% in these patients. In these trials, what happened was they all got the anthracycline first and then got the trastuzumab afterwards. If you take that approach, you drop the cardiotoxicity down to about 2 to 4%. But actually, if you don't give an anthracycline at all, you don't really see much cardiotoxicity with trastuzumab. So it appears that the adriamycin actually kind of primes the heart for this trastuzumab toxicity. In contrast to the cardiotoxicity you see with anthracyclines, however, it appears to be reversible. So what we do in patients that are getting trastuzumab is we check the rejection fraction, and if it goes down, what we do is we institute usually some heart failure medicine, or just even stop the drug for a few weeks, and it almost always recovers, and you can usually re-challenge them with trastuzumab as well. We don't really understand the etiology of this. As I mentioned, there are HER2 receptors on almost every cell in the body, including the myocardium. But somehow trastuzumab affects these HER2 survival pathways, and then for whatever reason it leads to apoptosis of cardiomyocytes, increased myocardial workload. At least that's one of the mechanisms that is out there. So it's not a huge problem, but we certainly do check echoes on these patients in the early stage setting to make sure that they're not developing any cardiotoxicity. So that's kind of where we kind of got to up until about 2000. So we talked about the estrogen receptor, tamoxifen, the aromatase inhibitors, and then the HER2 kind of era. In about 2000, what happened was that was when, around that time, the Genome Project came out, and we kind of entered this genomic era for treating cancer in general. And breast cancer was one of the first cancers that actually, if you like, was kind of genomically typed in a meaningful manner. And this is very important data that kind of taught us a lot about really that breast cancers, as we knew previously, but really told us for sure that they're not all the same disease. So what they did here was they measured the expression of 50 genes, and what they found was, as you know from this, red means the gene's overexpressed, green means it's underexpressed. What they found is using these 50 genes, they were able to identify about 4 or 5 different types of breast cancer. Now, we're not going away from estrogen receptor and HER2/neu because these two, the luminal A and luminal B, are both estrogen receptor positive. This ERB2 one is essentially HER2 positive breast cancer. And then we have this basal subtype, which is really also known as triple negative breast cancer because it doesn't have estrogen receptor, progesterone receptor, or HER2/neu. And so each of these entities really have their own natural history. If you look at probably a lot of the information we got from this was how estrogen receptor positive breast cancer are not all the same. Because if you look at the luminal A's in the dark blue and the luminal B's in the pale blue, what you find is the luminal A's have a pretty low recurrence rate. This is looking at distant metastasis shown here. But you can see their survival is actually very favorable. The luminal B's, however, even though they're estrogen receptor positive, have a very high recurrence rate over the first 5 years or so, and their survival is actually quite poor. Now, there's obviously genetic differences between these two different subtypes, but I think there's more and more suggestion that the luminal B's are resistant to endocrine therapy de novo. We'll talk about that in a second. Whereas the luminal A's are the ones that benefit from endocrine therapy. We'll talk about the basal X later on. But I just want to also show you, we were talking about HER2 positive cancers. The purple are HER2 positive cancers that didn't get any chemotherapy or trastuzumab. Look at the recurrence rate, very, very high over the first 4 to 5 years. And their survival, as you can see, it's quite poor, as you can see shown there. They're very different curves to what I just showed you now. So that's why I want to just tell you what a huge success story the use of trastuzumab and chemotherapy has been in breast cancer. Now, just one last thing about genomic typing. I just wanted to mention the 21-gene recurrence score, or Oncotype assay, which I think has been one of the most important tests that we've had in breast cancer. It's been approved for about 10 years now. And what it is it's basically specifically for estrogen receptor positive breast cancers, and it looks at 16 cancer-related genes and 5 reference genes, and kind of comes up with a number called the recurrence score. And this number gives you prognostic information, but it also helps to tell you whether the patient needs chemotherapy or not. So before we had this test, for patients with even node-negative ER-positive breast cancer, we used to give almost all of them chemotherapy. This is a trial that looked at tamoxifen plus chemo or tamoxifen alone, shown here. And you can see the benefit of chemotherapy. This is for distant recurrence. It's negligible, but yet because we didn't know who was going to benefit and who wasn't going to benefit, we gave everyone chemo. If you do the recurrence score, what happens is you have about half of them that have a low recurrence score and 25% that have a high recurrence score. There's also an intermediate group that I didn't put up there. But as you can see here, in the patients with the low recurrence scores, there's absolutely no benefit from chemotherapy at all. In the patients with high scores shown here, you can see there's quite a mammoth benefit from using chemotherapy. So now we know which patients need chemotherapy. And just to tell you how important this is, there's about 100,000 new cases of ER-positive node-negative breast cancer diagnosed in the US annually. Looking at this, 50% of them will have a low recurrence score. So that basically means that you're saving 50,000 patients, probably at least a year of chemotherapy that would have no value to them whatsoever. We're now moving into using this in the node-positive setting as well. So personally, I think if you've got a low recurrence score, it doesn't matter how many lymph nodes you have, chemotherapy is not going to help you. The way that you help these patients is by giving them longer durations of endocrine therapy, which I didn't have time to talk about today, but we talked a lot about 5 years of tamoxifen, but we are tending to give longer durations of tamoxifen. So this is a very important test. So I think we've been doing very well. The target therapies I've shown you have definitely improved outcome. The genomic subtyping has really helped our understanding of, that there are all these different types of breast cancer. So why are we still losing all these women to breast cancer every year, 40,000 women, and it hasn't changed that much? It's because even though we have good therapies, resistance develops to these therapies. And that's really one of the critical things and something that I think we've been very involved with in our breast program. So first of all, just to talk about endocrine therapy. At the time I was with Craig Jordan, we spent a lot of time working out the mechanisms of why tamoxifen stopped working in breast cancers or even didn't work at all. So let me just explain this cartoon. So here's an estrogen receptor positive breast cancer. Here's the estrogen receptor here. When it's sensitive to endocrine therapy, the estrogen receptor is just a straight target. All these drugs work great. However, as resistance occurs, a number of things happen, one of which is that you get other proteins that start driving the cell. Some of them are our old friends like HER2, but also other receptors on the cell surface. And they set off these phosphorylation cascades that alter the estrogen receptor in a way we don't really understand very well, but probably affect the coactivators that bind to the estrogen receptor. And this basically, for whatever reason, renders the estrogen receptor no longer an effective target. So we've done a lot of work looking at targeting. We have drugs that target all these proteins. And there's been trials looking at these different drugs, but they've been kind of so-so in terms of their efficacy. But the good news is that all of these pathways all end in this one protein called mammalian targeted rapamycin, or mTOR. So one of the thoughts was if you inhibited this particular protein, then you maybe turn off all these phosphorylation cascades and you could reverse resistance to endocrine agents. So again, it's kind of like looking for a target in these resistant cells. The other protein I'm going to talk about is CDK, or site-independent kinase, which is also, as I'm going to show you, important in resistance. And again, it appears to be able to reactivate or reverse resistance to endocrine therapy. So just talking about the mTOR inhibitor first of all, this very large study looked at adding an mTOR inhibitor in with endocrine therapy in patients with endocrine-resistant cancers. So what they did is they took patients who had prior endocrine therapy, switched the endocrine therapy to the aromatase inhibitor exemestane, and then added an mTOR inhibitor in. And what you can see here is there's about a 6-month improvement in disease control when you give the mTOR inhibitor in combination with the endocrine therapy, which, as you can see, is highly statistically significant. And the curve split very early in favor of the mTOR inhibitor, suggesting that it is indeed hitting resistance mechanisms. The other thing I always look at in these trials is the definition of endocrine resistance really is if you progress within 6 months in the metastatic setting. The median progression-free survival on this arm, as you can see, is 4 months. So this does suggest that most of these cancers were indeed endocrine resistant. So while I was in Dr. Jordan's lab, we, as I said, were focused very much on resistance to tamoxifen. So we had this model where we basically developed xenografts of estrogen receptor positive breast cancers in mice, and then we basically gave the mice tamoxifen for years and years. And after about a year or so, they become resistant to tamoxifen, so they actually start growing in response to tamoxifen. And if you keep them exposing them to tamoxifen, what happens is, after about 4 or 5 years, they go from being essentially HER2 negative to actually having expression of HER2 on the cell surface, as you can see. So I think you can clearly see here this is completely HER2 negative. This is about a 2+ for IHC for HER2 shown here. So we're very interested in that. Other groups had shown it as well, and it's been very consistent with what I showed you in the diagram that HER2 starts driving the cell. The reason we're interested is because at the time, trastuzumab was one of the only targeted therapies that we had for targeting upstream growth factors. If you look, however, at what happens to human tumors, we looked at the expression of ER, PR, and HER2/neu in patients with ER-positive breast cancer at the time of diagnosis and then at the time of recurrence when they've been on tamoxifen. And what we found was that at diagnosis, only a quarter of them were HER2 positive, 50% were HER2 positive at recurrence. So again, suggesting this was a real phenomenon. And then going back to the animal model, we were able to show that if you gave trastuzumab, you block the stimulatory effects of tamoxifen in this model. So here's what happens to these tumors if you give them tamoxifen. If you give trastuzumab, you can see you can block that effect shown there. And these cancers don't have very much expression of HER2, so it's kind of interesting because they're not your classically HER2 positive cancers, but yet trastuzumab appear to be effective. So while I was at Emory, we did this trial, which was specifically focused on patients who had what we deemed were endocrine-resistant cancers, because they had to have progressed within 6 months of endocrine therapy in the metastatic setting. They had a biopsy prior to going on, and we measured ER and PR and HER2. If they were 3+ for HER2, we didn't actually put them on the trial because they could get trastuzumab off the trial. We were looking for patients who had moderate expression of HER2. And what we did in contrast to the study I just showed you with the mTOR inhibitor was we didn't switch out their endocrine therapy. What we did was we added them, or we basically started them on either trastuzumab or everolimus. So these drugs were added into the endocrine therapy because what we wanted to know was, were we going to be able to reverse resistance to endocrine therapy using these agents? So I hope that kind of makes sense. The trastuzumab was to block the upstream HER2, and the everolimus was to block the mTOR inhibitor. And what we found, this is just an interim analysis of this data, was that the trastuzumab unfortunately didn't work very well. The disease control was only about a month and a half. There were some patients that actually benefited, though, so we have some tissue that we want to look at and work out why they benefited. But the patients who got the everolimus had a median progression-free survival of 6 months, even though we hadn't changed out their endocrine therapy. And we had patients, as you can see, up to 15 months on. I actually had a patient who had progressed within 3 months of starting letrozole. We kept her on the letrozole, gave her everolimus, and she remained on the study for 2 years. So I think because we didn't change the endocrine therapy, this is evidence, more evidence that the mTOR inhibitor is actually reversing resistance to endocrine therapy. And then the other one, just to mention, is the CDK inhibitors. So cyclin-dependent kinases are a group of kinases that are involved in cell cycle progression. So basically, cyclin D is here through retinoblastoma protein. It starts activating cell cycling. So if you block it with a CDK inhibitor, you turn off cell division. And for whatever reason, when the CDK inhibitor palbociclib was looked at in preclinical studies, it seemed to be only effective in ER-positive breast cancer. So these are all the ER-positive breast cancer cell lines shown down here. And you can see that if you look at the number of cells, it's very effective in these cell lines, but it doesn't work at all in these ER-negative cell lines. So again, we don't really have a mechanism for that, but that's what was found. So CDK inhibition is effective in resistant breast cancer, endocrine-resistant breast cancers. This was a study that was just published at ASCO, basically showing that if you add in the CDK inhibitor with endocrine therapy, what happens is you get about a 5-month improvement in disease control. And again, you can see the curve split very early in favor of the CDK inhibitor shown here. So these two drugs, everolimus, which is the mTOR inhibitor, and palbociclib, which is the CDK inhibitor, have been approved for treating metastatic ER-positive breast cancer. Again, it all comes back to finding the target in the resistant cancers and then finding therapies that you can direct towards it. So just in the last 5 minutes, just want to talk about triple-negative breast cancer, which is what I was more involved with when I was at Emory. So we're back to our curve shown here that I showed you before. And the triple-negative or basal-like cancers, which are kind of synonymous, have this very classical recurrence pattern. So this is looking at time to distant metastasis shown up here. And what you can see is that these cancers have an incredibly high recurrence over the first 2 to 5 years. You can see here that about 70% of the patients have actually developed distant metastasis, and their survival, as you can see, really is quite poor. However, one of the positive things that I do point out to patients is that with triple-negative breast cancers, if you make it to 5 years, your likelihood of having a recurrence is very, very low. In contrast to ER-positive breast cancers that can recur many, many years out, triple-negative breast cancers you can definitely cure. They don't recur after 5 years. So overall, they tend to be very high-grade and aggressive. Lots of problems with them in terms of therapeutic options because we only have chemotherapy. That's the only approved therapy for these cancers. But about 2/3 of these cancers are actually intrinsically resistant to chemotherapy. So that's one of the reasons they have such a poor prognosis. And then there are no therapeutic targets in triple-negative breast cancers that we've been able to utilize yet to develop therapeutic options for patients. Epidemiologically, they are interesting because unlike ER-positive breast cancers that are more likely to occur in older women, these cancers are more likely to occur in younger women. And also, they are have higher incidence in both African American and Latina populations. So this was some work we did in Atlanta, looking at the SEER registry there, looking at women in Atlanta under the age of 55. And we've got African American and Caucasian women, as you can see shown here. So when you look at very young women under the age of 35, you can see that whether they're African American or Caucasian, they have a very high incidence of triple-negative breast cancer. However, when you get to 35, there's a precipitous drop in the Caucasian women, as you can see. But you just don't see the same drop in the African American woman. And overall, many studies have shown this, that African American women are about twice as likely to get triple-negative breast cancer compared to Caucasian women. We don't know why that is. We don't know if it's environmental, genetic, a mixture. We don't know at this time point, but it's definitely a definite finding. On top of that, we also found this group of women that, unfortunately, the African Americans had a much worse survival. You see, the Caucasian women did reasonably well, but the African American women, as you can see, had a very poor survival. And partly, some of this could be socioeconomic, certainly from the survival patterns. So we have made some progress in these cancers, and sorry, this is kind of a complicated slide, but it's like when I was showing you the heat map showing the different types of breast cancer. This is a different set of genes, basically, that have shown us that there are about 5 or 6 different types of triple-negative breast cancer. So 2 of them are basal-like, which basically means that they're driven by genes that are involved in DNA repair. The only difference is that this one also involves growth factor signaling. There's an immunomodulatory subtype, which medullary, a rare type of breast cancer, fits in there. That's pretty interesting because one of the hottest things in oncology right now is tumor immunology, so it'll be interesting to see some data from this group. There's 2 that have a mesenchymal phenotype that I'll talk about. Metaplastic cancers fit into them. These are quite different, though, because unlike other triple-negative breast cancers, this subtype tends to be very low-grade and kind of unaggressive. And then this really fascinating subtype shown down here, the luminal androgen receptor subtype, which actually looks kind of like an estrogen receptor positive breast cancer, but it's estrogen receptor negative. But in contrast to being driven by estrogen receptor, it's driven by androgen receptor. So this, of course, is very good news because we have lots of agents that target the androgen receptor. So just to talk about the androgen receptor subtype, first of all, so not only is that luminal androgen receptor subtype androgen receptor positive, there are other triple-negative cancers that are also androgen receptor positive. So the initial study that was done looked at bicalutamide in 26 patients who had AR-positive triple-negative breast cancer and saw some patients got disease control about 20% at six months. So it was interesting. However, a better drug is enzalutamide. It's a newer drug than the bicalutamide. At least in preclinical studies with androgen receptor positive triple-negative breast cancer, you can see it looks very effective in inhibiting growth. So here's the vehicle-treated mice, as you can see shown here, and here's with a higher dose of enzalutamide, very effective in controlling growth. So at our national meeting this year, there was a study published, or presented rather, where they looked at patients with androgen receptor positive triple-negative breast cancer and just treated them with enzalutamide. And they did find some activity with the median disease control of about 15 weeks. It was slightly higher in patients at a higher level of expression of androgen receptor. So again, the more expression you have of the target, the more likely you are to benefit. They also were able to develop a genomic signature that was associated with benefit from this drug. So preliminary data, but very exciting. So we thought about this, and with Dr. Rampurwala from our group, we basically thought, well, if CDK inhibitors work well for ER-positive breast cancers, what about looking at CDK inhibition in combination with androgen receptor blockade in AR-positive metastatic triple-negative breast cancer? So we just got approval for this study, which will be androgen receptor positive metastatic triple-negative breast cancer, and they're going to get enzalutamide with a different CDK inhibitor. And we'll do a bunch of correlative studies as well. And we're particularly excited because the Big Ten, actually, in the last few years, has actually started up a cancer research consortium, which includes 12 out of 14 of the members of the Big Ten. And this is going to be the first breast cancer trial that's going to be run through the Big Ten, so we're very excited about that. And then very lastly, just to talk about the mesenchymal subtype. This is some work that I did at Emory. So the mesenchymal subtype, they don't respond well to chemo. They don't have very good treatment. One of the things that we were focused on was insulin growth factor receptor 1. And what we found is that IGF-1R is expressed in a number of different triple-negative breast cancers. You can see here it's expressed in a basal-like one shown here. The basal-likes have an epithelial appearance. And also this mesenchymal line here, you can see high expression. So we wanted to see what IGF-1R was doing in these triple-negative breast cancers. So what we did was we knocked it down, as you can see shown here, in this epithelial line and this mesenchymal line. And what happened was really very interesting, because in the epithelial line shown here, you can see it's clearly epithelial looking at it. What happens when you knock down the IGF-1R is the cells become mesenchymal. And believe me, that's a bad thing, as I'm going to show you. You don't want that to happen. Along with the markers that are associated with epithelium-mesenchymal transition shown over here. In the mesenchymal ones, however, shown here, you can clearly see the mesenchymal. When you knock out IGF-1R, you can see they take on this epithelium form, and we confirmed it with viamentin and ecoadherin. So this is a good thing. And why it's a good thing is shown here. So if you look at the invasive properties of the cells, in the epithelial line shown here, it does just fine when IGF-1R is present. As you can see, very low level of cell migration and invasion. When you knock out IGF-1R, however, look what happens. You get this really marked increase in invasion. And this is very interesting because IGF-1R inhibitors have been really ineffective in the clinic, and particularly in lung cancer, and most of those would be epithelial. So you wonder if this was some of what was going on, essentially, to explain these negative trials. But what we were really interested in was, in contrast, in the mesenchymal ones that were invading like crazy at baseline, when you knock out IGF-1R, you can see that you get a very marked decrease in invasion shown here. So that's definitely a good thing. Now, the problem with IGF-1R is that, unfortunately, we don't have good drugs. So we looked at other routes around this, and we looked at two focal adhesion kinase inhibitors because of some literature suggesting that they can affect IGF-1R signaling. And what we found was that if you look here, these are just mesenchymal cell lines shown here. If you knock out FAK, or focal adhesion kinase, what happens is you get a decrease in the expression of activated and total IGF-1R, as you can see shown here. So then we wanted to see pharmacologically if these FAK inhibitors that are currently in development would be something that would be useful in these mesenchymal cell lines. So if you just look over here, these are mesenchymal cell lines that express IGF-1R. And what we found is that the FAK inhibitors decrease colony formation and decrease invasion in these mesenchymal cells with IGF-1R. If they don't have IGF-1R, very interestingly, the FAK inhibitors don't do anything. So this is something that we want to confirm. But our ultimate goal, which we're quite a ways off from, is basically, because of all these subtypes of triple-negative breast cancer, we'd like to do a trial specifically for the mesenchymal subtype. So our thought was to look at metastatic triple-negative breast cancer that has mesenchymal markers and treat with a FAK inhibitor with or without chemotherapy, and we'll obviously do correlative studies as well. So that's ultimately our goal, working with Patty Keeley, who's got a lot of experience in this area. So just to conclude, hopefully I've showed you that we have been very fortunate in breast cancer because we've been able to target hormone and HER2 receptors for many years, and hopefully I've shown you that that has improved outcome for patients. However, we have a long way to go because we still have way too many women dying from breast cancer, and the availability of genomic typing has led to a good understanding of different subtypes of breast cancers and their complexities, but also yielded more targets that we know we'll be able to develop drugs towards, which will hopefully lead to more effective treatment for patients. So I still think that if you look at the bullseye, we're probably up around here. We really want to get in here because this is where you're going to have the targeted treatments that really only affect the cancer cell and don't affect the normal tissue. And just to thank, this is the UW breast team shown here, the Emory breast team, and then people from the Jordan lab. Thank you very much.
We have time for just a couple of questions.
Yes, Mark.
So the earlier data about the type that saving potentially 50,000 women from therapy, that's such a profound result. Is that something that's widely adopted, or is the adoption of that approach slow?
It's actually been fairly widely adopted. I still think people are a little bit selective in who they send it on, but I personally have to say I send it on almost every patient with node-negative breast cancer. But overall, I think it has been widely accepted. For example, Medicare actually even pay for 1 to 3 positive lymph nodes to do it. So there are, which I didn't mention, there's 2 prospective trials, one that's accrued and one that hasn't, that's validating this test. So I think that will really take it home. It is a fairly rudimentary test because really the genes that are involved, a lot of it's weighted on the proliferation. So people say, well, you can just do Ki-67, it's going to be the same thing. But I don't think it is actually. So I would say for a molecular assay, it's been pretty widely used, and I think it's very important. Because when you think about the numbers, it's been around for 10 years. That's at least 500,000 women who've saved chemotherapy, which is, I think, very important. Yes, Bonnie?
Yeah, thank you. So I'm wondering, with the African American women who are more likely to have triple-negative breast cancer, 2 questions. Is that controlled for socioeconomic status? And 2, do you see that same phenomenon in other black populations or just African American?
So that's it. So the question is just about the African American women, the triple-negative breast cancers. The first question was the data controlled for socioeconomic status. Our data was controlled up to a point, but actually if you look at other series, so for example, there was one that came out of Walter Reed, so it was equal access, they saw the same thing. So it appears to be more than socioeconomic, although I think that's a very important question that we kind of struggled with. The second question is actually very interesting, which was about, what about other black populations? In actual fact, there's some data out of Ghana. The University of Michigan have a project out in Ghana that actually shows that over there, the rate of triple-negative breast cancer is even higher. It's 60 to 70%. So it suggests that there is some genetic component to this, although we can't say that conclusively. But I do think that's a big question out there, and it kind of makes sense that the African American would have a lower rate than the African patients. The University of Chicago people work with Nigeria, and they didn't find such a high rate over there, but the Ghanaian population, very, very high rate. So.
Thank you very much for stimulating.